Assalamu alaikum everyone. The next topic of discussion is leprosy, also known as Hansen disease, which is a chronic infectious disease caused by Mycobacterium leprae. Its peak incidence is usually between 10 to 15 year and 30 to 65 year, and it is usually common in male as compared to female. And it's endemic to tropical regions like India, Brazil, Indonesia, Nepal, Myanmar, and Nigeria. What is the underlying cause? So pathogen Mycobacterium leprae is an obligate intracellular acid-fast bacillus that cannot be cultured, and it thrives in cold temperature. Due to this, it has a strong tendency to affect the skin and nerves. What are the route of transmission? So we have close contacts, then we have respiratory droplets, and transmission usually required prolonged exposure, and some individuals seem more predisposed than others. Then we have infectious type, we have lepromatous leprosy, and the reservoir is infected humans, and the other is a mammal in the US known as nine-banded armadillos. So these are the reservoir, and the infectious type is lepromatous leprosy. Now, what is underlying pathophysiology? So pathophysiology of lepromatous and tuberculosis leprosy. Lepromatous, we have helper T cell type 2 response, so increased Th2 response. Due to this, the response of the Th1 is inhibited. So inadequate cell-mediated immune response, many leprobacilli. So the cell-mediated immune response become decreased and the leprobacilli grows. So many leprobacilli were present. There is increased antibody production, hypergammaglobulinemia, but these are not protective, but these are the destructive antibodies that leads to different type of lesions. Nerve lesion are the result of Mycobacterium leprae invasion. So it invades the nerves and leads to different type of lesion. Mycobacterium leprae thrives at cold areas on the body like skin, mucous membrane, peripheral nerves, anterior chamber of the eye, upper respiratory tract, and testes. Tubercular leprosy, so there is increased Th1 response, helper T cell type 1. So there will be strong cell mediated immune response. Here the cell mediated immune response was decreased, while here the cell mediated immune response is increased. So there will be granulomas with epithelial cell and lymphocytes, but few or no leprobacilli. Here the leprobacilli were increased, but here the leprobacilli will be few or no. Nerve demyelination is a result of T cell mediated response, while here the demyelination was a result of Mycobacterium leprae invasion, and this is due to T cell and tubercular leprosy. Leprosy is slowly progressive chronic infection with spectrum of clinical manifestation depending on the degree of cell-mediated immunity. What are the clinical features? So its incubation about 3 to 5 years, and it can remain dormant even for up to 20 years. The clinical manifestation vary depend on the type of leprosy. Lepromatous, tuberculosis are several immediate forms collectively known as borderline leprosy. So these depend on the type of the leprosy. This is the table which show the clinical feature of lepromatous and tubercular leprosy. So in lepromatous, we will have multiple symmetrical macules, plaques, and nodule. There will be generalized involvement of the skin, and the nodule on the face may leads to leonine faces. The face will look like a line, and nodule can also ulcerate. There will be hypoesthesia of the skin. It is less common and occur only in the late stage of the disease. Hypoesthesia means that there will be decreased response to the sensory stimulations like pain, touch, and temperature. There will be supraciliary and ciliary metarosis, which is loss of eyebrows or eyelashes. While in tuberculosis, we will have few, usually 1 to 3 lesions, which will be localized, hypopigmented macules, plaques, and papules. So these will be hypopigmented with well-defined erythematous and raised margins. So margin will be well-defined. Lesions are dry, scaly, and anhydrotic due to loss of sweat glands, and due to autonomic neuropathy, there will be hair loss and there will be hyperesthesia of the skin. It's common in early stages, while later on leads to hypoesthesia of the skin. Then we have nerve involvement, so occur late but is more extensive. And there will be acral, distal, and symmetrical anesthesia. Usually begin with stocking gloves pattern that spread proximally. occur early but is localized. It occurs late but is more extensive. There will be asymmetric enlargement of one or many peripheral nerves. While here we will have symmetrical, and acute neuritis usually does not occur in tuberculoid leprosy. Then nerve involvement leads to nerve enlargement and peripheral nerve palsies which present with sensory motor and are autonomic deficits. Sensory deficit usually appear before motor. Fine touch, pain, and temperature perception are primarily affected, where fine touch will being lost first. Ulnar palsy will lead to clawing of the fourth and fifth finger, wasting of the dorsal and trochleus nerves, and there will be loss of sensation. Peroneal nerves palsy will lead to foot drop, and there will be posterior auricular nerves palsy and posterior tibial nerve palsy. Systemic manifestations, so there will be early prodromal symptoms like nasal stuffiness, epistaxis, hepatomegaly, and non-tender lymphadenopathy. These all are the finding in lepromatous leprosy, while in tuberculosis, systemic manifestations are usually not present. The three cardinal clinical manifestations of leprosy are, you have to remember that skin and nerves are involved in leprosy. So in skin there will be hypopigmented skin lesions and nerve thickening and peripheral nerve palsy. So skin there will be hypopigmented lesion and the nerve can lead to nerve thickening and peripheral nerve palsies. All peripheral nerve can become affected in leprosy, but the most commonly affected are ulnar and the peroneal nerves. Lepromatous leprosy manifests with leonine faces, which look lines like. There is low cell-mediated immunity in this condition and make it more lethal. So remember that in lepromatous, here L, line-like faces, and low cell-mediated immunity. So these are present in lepromatous leprosy. And this is the image which show a face appearance which look like the face of the lion. This image show hand deformities where the digits have been lost in patient with leprosy, and these are the hypopigmented macules in the leprosy. So these are the skin findings. Now diagnosis. So in diagnosis we have different types of tests like skin scraping or slit skin smear test. Test characteristics of modified Z-Nielsen staining of the scraping from the skin lesions, nasal swab, and our slit skin smear from earlobe are used to screen for the leprosy. And another type we have acid-fast bacilli smears microscopy, so rapid microscopic test for the detection of acid-fast bacilli. So smear are positive, while here the smears are negative. So the smears for the skin scraping or slit skin smear are positive for the lepromatous or they are negative for tuberculosis. Then we have punch biopsy. So in punch biopsy is followed by histopathological examination with modified Zeal-Nielsen staining and PCR of the biopsy is used to confirm the diagnosis. So in lepromatous on punch biopsy we will have foamy histiocytes full of bacilli. There will be lot of bacillus and few lymphocytes will be there and there will be numerous lepra bacilli. While in tuberculosis we will have granulomas formed by epithelial cell and Langerhans cells. There will be many lymphocytes with CD4 to CD8 ratio of 1.2 ratio 1 and there will be no lepra bacilli. Here we have numerous lepra bacilli and few lymphocytes. Here we have many lymphocytes with no lepra bacilli. Then we have lepromatous, so it's used to distinguish between the lepromatous and tubercular leprosy. Antigen is injected intradermally on the ventral forearm. The test is positive if duration is greater than 5 mm. Measure the ability of a patient to mount a T cell response. So it's measure the ability of a patient that how his immune system reacts to the antigen that is injected. So it does not diagnose the leprosy, but it can differentiate between lepromatous and tuberculosis. Can be positive in patient with no exposure or infection to the leprosy. It can distinguish between lepromatous because its negative result due to inadequate cell-mediated immune response. As we have discussed in lepromatous, we have increased Th2 response which suppress the Th1 cell-mediated immune response. That's why the patients with lepromatous will have negative result due to inadequate cell-mediated immune response, while tubercular leprosy is positive due to strong cell-mediated immune response that is due to Th1 helper cells. So it will be negative in lepromatous while it will be positive in tuberculosis. Diffuse hypergamoglobulinemia associated with epiromatous can cause false positive VDRL, rheumatic factor, and rheumatoid factor and or ANA test, and thus result in diagnostic confusion. So it can lead to confusion and can give false positive VDRL, rheumatoid factor, and or ANA test. In treatment, so we have multi-drug treatment for the leprosy. For lepromatous, all these three combinations are used: dapsone, rifampin, and clofazimine. While for tuberculosis, we can use dapsone and rifampin. For lepromatous, usually the treatment takes about 12 months, while for tuberculosis, it takes about 6 months. Then we have supportive therapies for treatment of leprosy reactions and rehabilitation like physio to prevent contractures and surgery to correct deformity due to nerve palsies and wound care. Then we have complications. So these are all complications like due to deformities. Then we have nasal complications, ocular complications, and other complications like orchitis, reactive amyloidosis, and leprosy reactions. Now we have different type of leprosy reactions: type 1 reaction, type 2 reaction, and Lucio phenomena. Type 1 is also known as reversal reaction, type 2 is known as erythema nodosum leprosum, and type and the third type is Lucio phenomena. What are the underlying mechanisms? So type 1 is delayed hypersensitivity reaction and cutaneous lesions. There are pre-existing libromatous lesions become red, warm, swollen and painful. So pre-existing lesions become red, warm, swollen and painful, and neuritis is common and severe. Systemic manifestations are not common and treatment is prednisolone. Type 2 we have erythema nodosum leprosum, so possible immune complex deposition. This is delayed hypersensitivity, while type 2 is immune complex deposition. There will be multiple red painful subcutaneous nodule appear symmetrically on the face, arm and or legs. This is neuritis is common and severe, and systemic manifestation are also there like fever, malaise, joint pain, tender lymphadenopathy, acute uveitis, orchitis, glomerulonephritis. Treatment, so supportive therapy to control fever, pain like insects, prednisolone and clofazimine. While here you have prednisolone. Then you have Lucy phenomena, which is cutaneous vasculitis, probably due to immune complex reaction. So it's vasculitis and immune complex is involved. Large, sharply marginated ulcerative lesion will be there that appear in crabs over the lower limbs and may recur episodically. So neuritis and systemic manifestation are not common in Lucy phenomena, while the treatment is supportive therapy, wound care, and prednisolone. Treatment of leprosy should not be stopped when leprosy reaction occur. The presence of tender nerve in patient with leprosy indicate a leprosy reaction. So remember that the tender nerves in patient with leprosy will indicate a leprosy reaction. So that's all about leprosy.